on to new things. Where are the new thresholds? Where do I think the new thresholds are in terms of outcomes, and especially in the rehab field? I think first we've got so many better statistical methods than we did 10, 15 years ago. Now there's things like path analysis or structural equation modeling. So before we'd put everything in as a predictor, now we can do it in steps and say, does knowledge improve self-efficacy, and does that lead to a better hack? So we can create a pathway and see if that's the truth or that's the truth for these patients. There's all sorts of different methods for what's called modern measurement. Some of you might have heard of RASH analyses or item response theory, which helps us to calibrate the importance of each item and how much it contributes to the understanding of disability or health. The PROMISE initiative is going on in the States, and it's going to have an item bank that's going to be available for us to tap into and use it to try to get items that we can compare across different disease groups, especially in the chronic disease area. And there's things like mixed methods and growth curve analyses that allow on the standard softwares, on SPSS and SAS, so that we can look for trends and trajectories and allow our patients to be different. So there's less focus on like a group mean change score, and you start looking for the nuances of, are there certain patients that change more or less than other patients? And let me show you an example. So this is maybe a typical trajectory. 360 patients that we followed, shoulder patients that we followed with the DASH in this situation, before and after they were undergoing physiotherapy for shoulder, soft tissue shoulder pain, no fractures, just the soft tissue issues. Mean change score was -30. So that's pretty good. That's a nice change score in the DASH. And that's typically how we present these results. But these are the actual lines for individual patients. And this type of analysis said to us, whoa, it's not really represented well by a mean change score of 30. There's actually a whole bunch of different patterns. And it creates these cluster groups and says there's some people in cluster A on the top left there who were pretty disabled at the beginning and didn't really change a lot. And then cluster B were equally highly disabled at the beginning, and they dropped off, which is a good thing on the DASH. So they recovered very nicely, very quickly. So maybe the better picture is to say something like this. We have 4 different trajectories in our sample, and patients are, potentially in group A, or they have a trend to look like group B or group C or group D, and we can get a lot more information than just saying a mean change of 30. And we're actually able to predict who's going to be in A, B, C, or D, for example. Second door, advances in e-outcomes. So there's all sorts of web-based data collection available now, and SF36 is online. The item banks are becoming available on PROMISE. Portable devices are practical and now becoming more cost accessible for clinical practice. We have PDAs or tablets going in several different clinics. In one study, we have it going in 36 different clinics around the province and pooling data in a centralized database. And what we can do with that is provide just-in-time information. So at one site where we have injured workers coming in, the injured workers come in and use touch screens to enter their survey data while they're waiting for their appointments, and then it goes into the database and spits out this form, and that's using Excel. So it's not using a really expensive software or anything. It just imports it into Excel, and that form is created that summarizes some of the prognostic issues, the DASH scores, some health issues, and where they are with their pain, etc. And then that becomes part of the discussion between the clinician and the client. So that makes it very real time for them. The third door I think is opening is around our efforts to address some of the measurement gaps. And I think many of you are probably working on measures of participation restrictions for paid work, unpaid work, or some of the costing, because Vancouver certainly is centered for that type of work. There's lots going on in quality of life, a lot going on around how to measure contextual factors and their impact on some of our health outcomes. Either we need to recruit measures from other fields and bring it into some of our chronic diseases like arthritis, or sometimes we need to create new scales to fill the gap. And always keeping a window pointing to the patient or the consumer as really an important source of what we need to be able to measure. And to that end, there are these patient-specific indices you might have come across, the COPM, the MyMOP, PET, MACTAR, where the patient actually generates their own items and nominates what's important to them. So the content validity for that person is excellent. But different items between respondents make group means and mathematical operations difficult to do with these scales because the number doesn't have meaning across people. It has meaning for that one person. But then Alan Tennant does a lot of work with rash modeling, and he's offered up a possible solution using rash techniques and pooling a whole bunch of items and trying to calibrate a mass number of items that are important to patients. And then the patients can choose from those items, and we can get some talk across different people's scales because they can choose their items from that big pool. It's interesting, I think, that some of the doors that are opening are actually revisiting our roots, because the history of patient-reported outcomes was to create numbers to represent our patients' stories. And the efforts now are seeing if we can recreate patient stories by having the right numbers out there. So we sort of are coming in a nice circle. So patient-reported outcomes, I think we're building on a very great foundation, half a century of tool development, 2 decades of really developing some solid standards for how to measure these things. We have good windows. Perhaps we could lean to the right a little bit more. And we have lots of opportunities opening up to us in the future in this area. So in conclusion, I would say try to avoid hanging up a do not disturb sign on your door. Be open to the new advances, let technology help, and listen to new ideas that are coming up. But remember that what comes out of our measures are numbers, and numbers are often mistaken to be facts. So we always need to consider the consequences of being wrong when we use our different tools, and always pursue the way to be right with what we're measuring. And this always struck me, that maintaining the quality of our health measures is important, for the information collected using them influences decisions that affect the welfare of our patients, and at a policy level guides major expenditures of public funds. Thank you.
Thank you, Dorcus. Any questions from the audience? Don't be shy. I'll ask the first question.
Oh, okay.
I'm intrigued by your comment about the next stage of doing research, looking at the full circle of using outcome data to create patient stories. Mm-hmm. I'm wondering if you can comment on some of the work that you know of that pursuing in that area, because it's certainly interesting. It's very relevant, to the patients.
Right. So the question was around how, when we're talking about the circle of the patient-reported outcomes are now coming to create patient stories, are there any examples of how that's being done? And I think there's probably several of them out there. There's a lot of initiatives trying to develop core sets, and ones that represent not only the clinical needs for it, but also really representing the patient's input into what they think needs to be measured to tell their story. And now with all the new modeling techniques, I know there's several projects that are trying to look at modeling ICF after a certain procedure, and then even following it over time to see if that model sticks over time, to really see if it's telling us a little bit more nuance about some of the patient issues and some of the relationship between the different outcomes.
Dorcus, can you comment on how, as clinicians, we can use normative data when it's available to examine where our clients fit on trajectories as opposed to looking at?
That's a great. Good. That's a really good question. So the question is about how to use, if there are normative data available, how we can use them and how we could, lay them over almost the trajectories that I was showing earlier. And that's a really good point, because some questionnaires that you have will have normative data. You need to just check and make sure it's normative to your population, because sometimes they're created in other populations, and when they've actually done some comparisons, they found that even Canadians and Americans are different in what they value and what they appreciate in their health status scores. So there might be Canadian norms and there might be American norms that might vary slightly. But in terms of how you could use it, I think it's a really great idea. So those trajectories track an individual's course over time. And what I've done is had sort of time grids across the horizontal and put some markers on it. So put the norm on. So the DASH, for example, has a norm score. So we can put what the general population would get on the norm and on the graph. And then we put some boundaries. So we know that people around 20 to 30 on this instrument tend to be able to go back to work. And people that are at 50 or 60 are really having a hard time working. So we put some of those little benchmarks on it to just guide interpretation. And then clinicians can then graph time and see when their patient has improved not like a certain amount of change, or when they've sort of entered the zone where a lot of people at that score are returning to work, or finding they can manage their problem, or when have they crossed that normative data. So I would use it to sort of create a pictorial diagram of when, like little benchmarks along the score, if it's available. Were you thinking of anything else for its use?
No, it's just that it's we're encouraged to use that information.
Yeah.
It's not readily available for every instrument and every population in that, but when it is, it's trying to figure out where is that fitting
Yeah.
In terms of achieving that. I guess that's the end state.
Yeah, it would be like an end state. But it might be because it's a general population norm, and sometimes the end states that our people tell us are okay are not, normal. They're okay sometimes with some disability or some challenges, but as long as they can cope with them. And so we have to be careful that we aren't trying to just normalize everybody. We have to allow them to experience it in their own way. But maybe there's a margin around the norm that you start saying, so is this good enough for you? Are you able to do what you need to do?
Any other questions? I also want to remind everyone that this session is actually being videotaped as we speak, and that's why Dorcus is repeating all the questions, because otherwise people will not be able to hear in the video recording. So for those of you who want to revisit the presentation, or for some of your colleagues who are not able to make it today, after the editing, we're going to put it up on the Department of Physical Therapy's website, and you'll be able to access it.